अस्सलाम वालेकुम। तो आज एक और लेक्चर के साथ मैं हाजिर हूँ। जेनिटल ट्रैक्ट इन्फेक्शंस इज़ द टॉपिक and this is going to be from for the medical students, and primarily it is going to be in English. So let's get started. So I'm going to divide genital tract infections into two categories. The first one is non-sexually transmitted infections, and the second one is, of course, sexually transmitted infections. So, the first one in non sexually transmitted infections is bacterial vaginosis. Bacterial vaginosis is caused by overgrowth of mixed anaerobes like Gardnerella and Mycoplasma hominis, which replace the usually dominant lactobacilli of the vaginal flora. So, you just have to understand that the normal vaginal flora is affected, and instead of lactobacilli dominating it, it's primarily these two bugs. Now this is particularly common in women of childbearing age. It is not sexually transmitted. We don't know why it happens, but we know the symptoms. So the symptom is a vaginal discharge which is profuse, whitish gray, and it smells very offensive. In textbooks, it is described as a fishy smell, and that is because of the amines that is released by bacterial proteolysis. Now, how do you diagnose bacterial vaginosis? Well, there's a criteria called as AMSIL criteria, and you need three out of four of these things for a diagnosis. So the first thing is a homogeneous gray-white discharge. I put up this last picture for you in which you can see per speculum that there is gray-white pieces of discharge, right? And then there's increased vaginal pH of more than 4.5. There is a characteristic fishy smell. This is called a positive whiff test. And under microscope, you can see clue cells, which are squamous epithelial cells with bacteria adherent to their walls. I have also included pictures of clue cells. I hope you understand. Now, the complications is there is obviously an increased risk of pelvic infection after gynecological surgery. And what is the treatment? Well, in some cases, it resolves on its own. If successfully treated, it does have a high recurrence rate. And for treatment, you can give metronidazole, 400 milligram orally thrice daily for 5 days. It is marketed as Flagyl in Pakistan. Then you can also give metronidazole 2 grams as a single dose. You can give clindamycin 2% cream vaginally at night for 7 days. The reason we give it at night is because it will have maximum, contact, and also at night time you are resting, so it will get maximum exposure. Then, lifestyle advice, well, avoid vaginal douching or overwashing, which can destroy the natural vaginal flora. I don't know why people do this. The body has its own mechanism. The vagina has its own mechanism of self cleaning. There is no need to externally take these measures to clean it because you ruin the flora. And if you ruin the normal flora, you are inviting pathological flora to take over. So that's just wrong. What are the implications of bacterial vaginosis in pregnancy? Well, there's an increased risk for mid trimester miscarriage, preterm rupture of membranes, and preterm delivery. Now, let's move on to the next infection, which is candidiasis or thrush. So, we know that it is a fungal infection. 90% of the time, it is Candida albicans, but it can be something else as well. It is very common, and susceptible people usually are immunosuppressed, or they have recently just completed a course of antibiotics, or they're pregnant. And pregnancy, as you know, is also an immunosuppressive state, and there's a hormonal imbalance. Aside from that, there's diabetes also. This is also a low immune state. Then there's anemia. In the symptoms, there is curd like white vaginal discharge, and it is usually associated with vulvar itching and soreness. They can also be dysuria and superficial dyspareunia. So here are a few very helpful pictures. So in the first picture, this is a picture of the vulva, and you can see that there is redness and there are fissures. Fissures are like cracks, right? So that is a very common finding. Then the patient will tell you that the patient feels very itchy in this area. Then, if you look at the speculum picture in the middle, you can see that there is white, thick discharge present. It resembles GERD. That's a very helpful thing to remember. Then, in the third picture, you see that this is a microscopic picture and it shows you pseudohyphae on the wet slides. So, you can obtain this sample by doing a high vaginal swab or a low vaginal swab. So you can very easily diagnose this condition. So, what are the complications? Thankfully, it does not have very significant complications unless the patient is severely immunocompromised. The treatment is obviously antifungals. So, many patients are silent chronic carriers. They don't need treatment. But if the patient comes to you with symptoms, obviously you have to treat it. So you can give clotrimazole 500 milligram pessary with or without topical clotrimazole cream. Here in Pakistan, you can find it, for example, under the brand name of Canesten, right? Then there's fluconazole, 150 milligram single dose, but you cannot give this in pregnancy. You can give clotrimazole in pregnancy. It's very convenient because it's a one time dose only. So yeah, you have to clear it with your doctor if you are suffering from any particular condition. So advice is you can avoid underwear altogether, and if you have to use cotton underwear, stay dry, avoid chemical irritants like soap and perfumes and all these products and bath salts. Avoid all this, right? Then implications in pregnancy. Just for your information, this is very common in pregnancy, and apparently, thankfully, it does not have adverse effects. You can treat with clotrimazole pessary and topical cream. Topical imidazoles are not systemically absorbed and are therefore safe at all gestations. Now we'll talk about sexually transmitted infections or STIs. First of all, obviously, it tends to affect the young population more, young adults who are more sexually active. Partner notification is very important, and not just notify them, but also treat them to get an end to this. And also, as a doctor, you have to respect the patient's confidentiality and you should refrain from being judgmental. Risk factors for STIs include multiple sexual partners, two or more in last year, concurrent partners, no use of barrier contraception, involvement in commercial sex industry, and STIs in partner or other STI. It may include transmission by anal, oral, vaginal sex, sometimes even by intimate skin to skin contact. Some STIs may spread through contaminated needles or vertical transmission from mother to child during childbirth or through blood transfusions or breastfeeding. Some STIs can cause infertility in both men and women if not treated timely. Hepatitis and HIV are discussed in another video, and barrier contraception is very important for protection against STIs. So, as a doctor, you should be aware of important points in history and testing. So, generally, symptoms like lumps and bumps, which is like lymphadenopathy, ulcers, rash, itching, intramenstrual menstrual bleeding or postcoital bleeding, lower abdominal pain, dyspareunia, sudden change in discharge, they're all pointing towards STIs. Past history of STIs, risk factors for bloodborne viruses. If your patient is an IV drug abuser or a bisexual male partner, patient or partner from a high HIV prevalence area, you should be very aware of all this information. Testing should be done at the time of presentation. Incubation period before tests for STIs become positive can give false negative after a single episode of sex. For bacterial STIs, this is 10 to 14 days. For HIV and syphilis, it may be up to 3 months. Now, let's talk about chlamydia infection. So, chlamydia trachomatis is an obligate intracellular parasite. The symptoms are dysuria, vaginal discharge, irregular bleeding, intramenstrual bleeding, or postcoital bleeding, 70% cases are asymptomatic. So the complications can be pelvic inflammatory disease, perihepatitis, Reiter syndrome, tubal infertility, and risk of ectopic pregnancy. How do you diagnose it? Vulvovaginal swab, which can be self-taken or taken by the healthcare team. Endocervical swab for nucleic acid amplification test or NAAT. The treatment is azithromycin 1 gram single dose or doxycycline 100 milligram BD for 7 days. Contact tracing and treatment for partners is very important. Then, implications in pregnancy. It is associated with preterm rupture of membranes and premature delivery, neonatal conjunctivitis, neonatal pneumonia, and you have to note that treat pregnant women with erythromycin 500 milligram BD for 10 to 14 days. Now we'll talk about herpes simplex. Herpes simplex DNA virus है and HSV1 orolabial slash genital and HSV2 is genital only. Symptoms of primary HSV infection include number one, the prodrome, which is tingling, itching of skin in affected area. Then there's flu-like illness with or without inguinal lymphadenopathy, vulvitis, and pain. It may also cause urinary retention. Small characteristic vesicles are seen on the vulva, but can be atypical with fissures, erosions, and erythema of skin. Symptoms of recurrent HSV infection thought to be from reactivation of latent virus in the sacral ganglia, and it can be triggered by stress, sexual intercourse, and menstruation. The complications and diagnosis of HSV infection. The complications are meningitis, sacral radiculopathy causing urinary retention and constipation, transverse myelitis, disseminated infection. And the diagnosis, usually, you can have an idea from the typical rash. You can do PCR testing of vesicular fluid, culture of vesicular fluid. Serum antibody tests are of no use for diagnosing primary herpes. The treatment. There is no cure for genital herpes. Symptomatic relief with simple analgesia, saline bathing, and topical anesthetic. Oral acyclovir 200 milligram 5 times a day for 5 days, double dose and length for immunosuppress. Topical acyclovir does not help. Condoms abstinence while prodromal symptomatic can reduce transmission rate. Now, gonorrhea. Gonorrhea is caused by Neisseria gonorrhoeae, which is an intracellular gram-negative Rhiplococcus. You can see that in the picture. Symptoms are a lot of cases are asymptomatic, but a lot also have vaginal discharge, lower abdominal pain, intermenstrual bleeding, or postcoital bleeding. You can diagnose it by doing an endocervical or vulvovaginal swab and urethral, pharyngeal, and rectal swabs if contact with gonorrhea. If it is diagnosed on NAAT, culture for sensitivity screening should be taken before starting treatment. Complications. Pelvic inflammatory disease, Bartholin or Skinner's abscess. Disseminated gonorrhea can cause fever, pustular rash, migratory polyarthralgia, septic arthritis, tubal infertility, and risk of ectopic pregnancy. The treatment. Ceftriaxone 500 milligram IM stat plus azithromycin 1 gram per oral stat. Spectinomycin 2 gram IM and azithromycin 1 gram PO stat if severe penicillin allergy is there. Contact tracing and treatment of partners is very important. Same antibiotics are recommended for treating gonorrhea and pregnancy. Implications in pregnancy. It can cause preterm rupture of membranes and premature delivery. Chorioamnionitis. Risk of ophthalmia neonatorum to the baby. You can see that in the picture. Then we come to syphilis. Syphilis is caused by Treponema pallidum, which is a spirochete. And I've divided the symptoms into three categories. You know that there is primary syphilis, secondary syphilis, and tertiary syphilis. Primary syphilis, 10 to 90 days post infection. Painless genital ulcer called a chancre on the cervix. It can be unnoticed. There is usually inguinal lymphadenopathy. Secondary syphilis occurs within first 2 years of infection. In this, you have generalized polymorphic rash affecting the palms and soles, generalized lymphadenopathy, genital condyloma lata, and anterior uveitis. And tertiary syphilis presents the latest. and 2 years up to 40 years max. And it presents very seriously as neurosyphilis or cardiovascular syphilis or gumata, inflammatory plaques or nodules. I've put up pictures, hopefully, this helps. The diagnosis, there's a specific treponemal enzyme immunoassay for screening, IgG positive, IgM. Primary lesions smear may show spirosheets on dark field microscopy. I put the first picture here showing this. Then there's quantitative cardiolipin, not treponemal test, that is rapid plasma reagin are useful in assessing need for and response to treatment. Then there's trichomonas. It is caused by Trichomonas vaginalis, which is a flagellated protozoan. It is found in vaginal, urethral, and paraurethral glands. The cervix has a classic strawberry appearance due to punctate hemorrhages. You can see that in the second picture, as well as the third. So the speculum exam is very informative. The symptoms include vulvar itching and soreness, dysuria, and vaginal discharge, which is green, frothy, and bad smelling. You can see that in the first picture. Culture media diagnose 80% of the cases. Complications, there's some evidence that trichomonal infection might enhance HIV transmission. The treatment, metronidazole, 2 gram per oral single dose, or metronidazole 400 to 500 milligram twice daily for 5 to 7 days. And number 3, contact tracing and treatment of partners. Implications in pregnancy, it is associated with preterm delivery and low birth weight. Now we'll talk about HPV, which is human papillomavirus. This is a DNA virus and it has different subtypes. 6 and 11 cause genital warts, and 16 and 18 are associated with sin and cervical neoplasia. Symptoms, it can be asymptomatic. You can have painless lumps anywhere in the genito-anal area. There can be perianal warts, and that's very common in the absence of anal intercourse. Diagnosis is usually by clinical appearance. Sorry. Complications 16-18 are associated with high grade sin and cervical neoplasia. Smoking and immunosuppression both affect viral clearance, thereby increasing the risk. The treatment for genital warts, clinical treatment is removal of the visible warts, high recurrence rate due to latent virus in surrounding epithelial cells, cryotherapy, trichloroacetic acid, electrosurgery, scissor excision, curettage, laser. Home treatment, both contraindicated if there is pregnancy risk. So there's a podophylotoxin cream or solution self-applied and must be used for about 4 to 6 weeks. Imiquimod cream, also self-applied immune response modifier, may be used up to 16 weeks. Implications in pregnancy and vaccinations. Genital warts tend to grow rapidly in pregnancy and they usually regress after delivery. Very rarely, babies exposed perinatally may develop laryngeal or genital warts. It is not an indication for C section. HPV vaccination is recommended for all girls aged 12, 13. It covers 16, 18, 6, and 11 HPV types. I hope that you learned a lot from this video. If you like this video, please like, comment, share, and subscribe to my channel. And follow me on my social media, Instagram and Facebook. And I'll be back with another video. Allah Hafiz.